Okay, we should start. Welcome everyone. I'll continue the IGC invited lectures, and today we have with us Dr. Pere Barba. He achieved his medical degree and did his fellowship in hematology at Hospital Sant Pau here in Barcelona, and completed the training at the Hospital Saint Louis in Paris, in France. And he was a visiting investigator at the bone marrow transplantation service at Memorial in New York. He obtained his PhD by the Autonomous University of Barcelona. He's the coordinator of the Spanish CAR T-cell Working Party, and he's an active member of the ALL PETEMA group and also of the Acute Leukemia Working Group at the European Society for Blood and Marrow Transplantation. His research is focused mostly in CAR T-cells, overall in cellular therapies, even beyond CAR T-cells. We're talking just now about TILs, current case not sure, immunotherapy, ALL, allogenic cells, and transplantation. And he's an active member of the Spanish Acute Lymphoblastic Leukemia. They have here excellent members, the doctors Riveras, in our place. So he's currently the director of the CAR program at Hospital Vall d'Hebron in Barcelona, and associate professor at the Autonomous University of Barcelona and Vic. Thank you very much, Pere.
Thank you, Manel, for this kind introduction. And my disclosures are here, but probably the main disclosure is that I'm a clinician. So I'm a bit impressed of this audience with high knowledge of basic science, of that we're just talking before. Physicians have disappeared, almost disappeared from research centers. So my goal here is try to light you a bit on the potential questions that we are interested in the clinic, and then it's your job to work on the answers. So pretty easy work for me today. Today, I will be talking on CAR T cells, which is my main focus of interest, and I will be focusing also in concomitant therapies, because I will try to show you that CAR T cells are a very promising therapy for patients with cancer, especially for hematological malignancies. But these treatments are only part of a sequence of several treatments that patients receive during their journey. And all these therapies have an impact also on the outcome of CAR T cell therapies themselves. So the first question is, why CAR T cell therapies come to hematology? Well, there are several reasons, but I think one of the most important ones is because in several diseases like large B-cell lymphoma and acute lymphoblastic leukemia, we had a lack of standard therapies and a bad outcome of these patients. You can see here the study named SCHOLAR-1, which basically is a retrospective study, real world, of what the outcome of patients was before the advent of CAR T-cell therapies. And you can see that less than 20% of the patients beyond the second line of therapy achieved durable remissions. And similarly, there was no standard of care beyond this second line. So the CAR T cells came to this particular spot and were the first indications to be treated. Also in leukemia, I won't be talking about leukemia today. So I'm sure I don't have to explain to this audience what a CAR T-cell therapy is or how a T-cell receptor work, but just a brief reminder, we have B-cell receptors or immunoglobulin who directly bind to the antigen, namely infections or tumor antigens. And then we have the T-cells, which recognize antigens which are presented by antigen-presented cells through the TCR. So they do not directly identify the antigen from the tumors in this case. And what CAR T cells are is just like a mixture, a chimera of B cell receptor and T cell receptor. So we have the variable fraction of the immunoglobulin, which allows the direct recognition of the tumor antigen, and then the internal part of the TCR, which allows the immune response by T cells. So by this, we overcome the HLA barrier, which is a mechanism, as you know, of resistance that many tumors do, right? So with CAR T cells, we have a direct recognition, as I was mentioning, of the cancer cells and the lysis of those cells. But the CAR T manufacturing, some of you may know, is not simple. And although these are drugs or considered drugs from a regulatory perspective, the starting point are cells, right? So we start with the apheresis material from lymphopoiesis of a patient, because the approved CAR T cells today are autologous CAR T cells, meaning that these are individualized therapies for each particular patient and need to be produced. So we start from the leukapheresis material, then we select the mononuclear cells, and we do in some particular constructs or products a further selection, for instance, CD4 and CD8, and then the transduction of the receptor gene is done, usually using viral vectors, and then there is an expansion of the cells and the final product. And this takes around 3 weeks, the whole thing. So quite a long time for patients who have refractory disease and need to wait for this therapy. Another important point is, and I will tell you that in more detail in a minute, is that these patients need to receive what we call lymphodepleting chemotherapy. So we need to administer chemotherapy before the administration of CAR T cells, not because we want to control the tumor with this chemo, but we need to immunosuppress the patient in order to allow expansion and persistence of these CAR T cells. And from a patient perspective, this period is called the bridging period, because the patient crosses this bridge from lymphopoiesis to infusion of CAR T cells. And I will talk about the bridging period further in this talk. As you also may know, these therapies are not absolutely safe, as every drug in the market, and then they have several adverse events. The two most frequent and well-known events are cytokine release syndrome and immune cell-associated neurotoxicity syndrome, or ICANS, or neurotoxicity. CRS, cytokine release syndrome, is an inflammatory status that these patients suffer, usually 1 to 3 days after infusion, and is pretty similar than an infection, but without the microbiological agent, of course. And these patients have fever, hypotension, hypoxia, tachycardia, renal insufficiency, and so on. Of course, this is not mediated by microbiological agents. It's mediated by cytokines, and the main treatment for this complication is tocilizumab, which is an IL-6 receptor antagonist, which blockades the IL-6 receptor and lowers the inflammation. The second most frequent complication, and this occurs in around 80% of the patients in some degree, so almost everyone. Regarding neurotoxicity, this occurs a bit later, usually in patients who have previously experienced CRS, and the physiopathology of ICANS is less known. We know that CAR T cells can penetrate in the blood barrier, in the brain barrier, sorry, and in the CSF and the cerebrospinal fluid. But also some cytokines that have been produced during the CRS can also penetrate and produce the clinic of the patients in terms of confusion, aphasia, and these patients can also have seizures. The treatment for these complications, which is not as frequent, but probably more severe in terms of grading and also in terms of causes of death, is corticosteroids, a lymphotoxic effect. We have treatments for second line using IL-1 antagonists and so on, but I will not talk about that today. However, there are other frequent complications, and the most significant one are not that typical, are neutropenia and thrombocytopenia. So prolonged cytopenias, and some of these patients do not recover the function of blood marrow, of bone marrow during 3, 4, 5, even more weeks. And this, of course, is a very high risk for infections. And these patients continue to have infections months after the infusion of CAR T cells. There are other infrequent long-term events like psychiatric events, delayed neurological toxicities, and secondary malignancies, which have been very in the highlight field recently, because there have been some alerts you may be aware of T-cell lymphomas after CAR T-cell therapies. And all that results in significant toxicity I was mentioning, and also in mortality. And this is a recent meta-analysis published in Nature Medicine a few months ago, showing that the risk of mortality what we call treatment-related mortality or non-relapse mortality, dying not because of the malignancy, but of the consequences of the treatment, is between 5 to 10% of this treatment. So this is something we can allow, I would say, in cancer patients, but I think this is a very important and relevant information when we think of these therapies in other settings, like autoimmune diseases, where 5% mortality may not be an option for these patients who, in general, do not die in the short term. So with that being said, how do I see the outcome of CAR T-cell patients or the performance of CAR T-cells right now? So it's pretty similar of this bottle, half empty or half full, depends on what you think. So on one hand, we do have that the results on the right-hand side of CAR T-cells, and this is probably one of the most important retrospective studies from the French group, is better than what we had before in the SCHOLAR-1 trial study, or what we have now with, for instance, bispecific antibodies. I'm showing here the results of the IPCOR NHL-1 trial with epcoritamab, with a long-term survival of around 30%. With CAR T-cells, we can achieve around 50 to 45, 50% of long-term survival, but still, and this is the half-empty part of the bottle, around 50 to 60% of the patients are not cured with this therapy. We've done much better than we did, but still some room for improvement. And why is that? Well, there are a variety of reasons, but we have identified from a clinical perspective, using retrospective studies, large studies, some risk factors for resistance or recurrence of this disease. And I would say the two most important ones are the ones that you see here on the left. That's ECOG performance status, so the status of the patient, and the tumor burden, so the amount of tumor that you have. You can measure it with LDH, you can measure it by PET, you can measure it whatever you want, but all the trials, the results are similar. Patients who have more tumor burden do worse after CAR T-cells. Then there are other therapies, like the impact of previous therapies, as I will be discussing today, the type of response to bridging therapy, and comorbidities. Surprisingly, and this is uncommon in oncology, age does not seem to be an issue here. So older patients, of course, these are selected patients, do seem to tolerate quite well these therapies, or at least as well as younger patients. So in summary, the risk factors for resistance to this therapy are host-related factors, as I was mentioned, of course, tumor-related factors like genetics and the microenvironment, and also the issue of tumor burden and the CAR T-cell therapy itself. So we have CARs that seem to work better than others. And more interestingly, there are CARs that seem to work better in some diseases, and other CAR T-cells work better in other diseases. So with all that, and I will try to summarize what the journey of a patient, a hematological patient, let's say with a lymphoma, usually is. And I think this is important because in the second part of my talk, I will try to show you what we have been done in our group regarding the impact of previous therapies. So a general patient is diagnosed with a lymphoma one day, and then one day is considered to be a CAR T-cell candidate, right now in second line, a few years ago in third line. The patient receives apheresis, the collection of the cells, and then the CAR T infusion, and then unfortunately a few patients or some patients do relapse. And during all this process, these patients receive concomitant therapies. So at diagnosis, they receive 1 or 2 lines of therapies, then they relapse and then become a CAR T-cell candidate. While the logistics of CAR T-cells is put in place, these patients might receive additional therapies to control the disease, what we call the holding therapy. Then they undergo apheresis. They receive bridging therapy, as I was mentioning, to maintain the disease control until CAR T infusion. And then once before the infusion, they receive the lymphodepleting chemotherapy, and after relapse, they receive rescue therapies. And our interest in our group was to see what was the interaction with all these therapies with the outcome of CAR T therapies themselves. Because these therapies given before apheresis, so before the collection of CAR T cells, might have an impact on the T cell fitness. So remember, we produce the CAR T cells based on the patient T cells, and we have given chemotherapy or other therapies that damage T cells to these patients, the product itself might be not a good quality. And this is important in terms of responding to CAR T cells. The chemo that is given before CAR T cells, but after bridging, so here the CAR T product is not an issue because we have already collected T cells, but this lymphodepleting chemotherapy can have an important impact on the expansion and the persistence of the cells and as well as the infections of the patients. And the chemo that's given after relapse can have some cross resistance with a prior CAR T cell exposure. So the first study I want to present is a study that was published earlier this year, looking at the impact of previous bendamustine on the outcome of CAR T cell patients. So bendamustine is an alkylating agent with a funny story. It was a drug that was developed in the Eastern Germany, like around World War II, then was abandoned and then was used again recently in the last 20 years. And this is an interesting agent because has an impact not only on tumor cells, but also in the immune cells. And we know that has an impact on T cells by decreasing CD4 and upregulating the PD-1 and other checkpoints, but also has an impact on NK cells and dendritic cells. And it's an agent that's frequently used not only large B-cell lymphoma, but other types of lymphoma. So there was a concern on what was the exact impact of this therapy on the apheresis material and the effectiveness of CAR T cells. So what we did, and this is a work that was done by Gloria Iacoboni in our group, is to collect like more than 400 patients that had received CAR T cell therapies with lymphoma, and then we identified 80 patients that had received prior bendamustine. And there were some differences in terms of baseline characteristics between the patients that were exposed to bendamustine and those who were not. And this, has clinical reasons that we can discuss in the questions. I will not go into detail, but patients, for instance, who were bend exposed were more frequently transformed from other diseases like follicular lymphoma, where bendamustine is frequently used, were older, and so on. So there were differences between these groups. So what we did initially was to see what was the impact of prior bendamustine. And we were very happy to see that patients who were bendamustine naive seemed to have better responses. You can see in gray, better complete responses, more partial responses, and better survival than those who did receive bendamustine before. But of course, to be fair, we wanted to adjust, and we did a PSM, a matching, propensity score matching between these groups. And after the matching, these outcomes seem quite similar between both groups. So the effect of prior bendamustine was mitigated. And then what we thought is, well, these patients had a wide range of the last dose of bendamustine, so maybe the time matters. So we did identify those patients who received bendamustine within the recent times, and that was 9 months. I want to highlight that we did this study also with the 6-month cutoff and the 12-month cutoff, and the results were pretty much the same. But I'm showing here the 9-month, and you see again better responses in the patients who were bendamustine naive. This had an impact on overall survival, but after matching, this benefit remains. So not being exposed to recent bendamustine, and we did include here patients who had received bendamustine 3 years ago and consider it as bendamustine naive. We show the impact of recent bendamustine, the deleterious impact on the outcome of patients. As a matter of fact, we observe a continuous impact of the time of exposure. So you can see here on the x-axis the time, and then on the y-axis the hazard ratio. You can see a steady decrease on the hazard ratio for mortality as the time went by. So. And also, we saw some differences in terms of cellularity in trying to explain why this was an effect. And these are results of the T-cell subsets in the peak of expansion after infusion. So this is in vivo data from patients. And we see that although this was not significant, patients who had not been exposed to bendamustine had a higher peak of CAR T cells and a different subsets of T cells with less central memory and effector memory cells and more terminal effector in the peak of the patients compared with the patients who had received prior bendamustine. So once we showed the impact of bendamustine prior to the apheresis, we wanted to see whether once we have collected the cells, the use of this agent is important or not. Okay, we say we cannot, apparently we cannot use bendamustine in the recent time before apheresis, but what about using it after, once you have collected the cells? And we, again, use the same data set. Of course, we exclude the patients who had received bendamustine before, and we end up, and we exclude some patients who did not receive bridging therapy. So we end up with 181 patients who had not received benda and 62 patients who had received prior benda. Here, the characteristics of the patients were similar. And we did observe, and we split that, the outcomes according to the product. These are two CAR T-cell products. I will not go into detail, but although this was, there were some differences in terms of complete remissions. If we looked at overall remissions, that's complete and partial remissions, that is the yellow and the green, you can see that there were similar responses in patients who had received bendamustine and those who had not. And this is a bit complicated slide, but you can see here that there are two lines, for instance, in the upper plot that are very close by, which are the yellow and the green one, and two other lines that are very similar between themselves. And these are not being exposed or not to bendamustine. This was the responding or not to bridging therapy. So if you respond to bridging therapy, that matters in terms of outcome of CAR T cells, but it doesn't matter if you have responded to bendamustine or to other agents. And as bendamustine has an impact on T cells, B cells, and NK cells, and this is given here in this study as bridging therapy, so very shortly before, a few weeks before the infusion of CAR T cells, we wanted also to look at the infections, whether the use of this agent in these patients was associated with more risk of infections, and the answer was no. We did not see an impact on all kinds of infections and also in severe infections, so we concluded that bendamustine can be safely used as a bridging therapy. So we have covered here the previous therapies. We do not use holding therapy in Spain that much. In Germany, for instance, they use it more because they have different logistics. And we had covered also the bridging therapy. And now I will be focusing on the lymphodepleting therapy and the rescue therapies. And the third study I want to focus on, in the third point of interest of our group, is the impact of lymphodepleting chemotherapy. Remember, this was the chemo that's given a few days, 5 to 3 days before CAR T-cell infusion. And the main goal of this therapy is to immunosuppress the patient. And there are several studies, and there were several studies showing that patients with higher AUC or optimal AUC, so exposure of fludarabine, did better than those patients who did not have an optimal exposure. And optimal was defined on the different cutoffs that you can see on the plot. But the problem is that this AUC, this exposure, in most of the studies was calculated theoretically. So there were no samples of the patients. There was not actual measurement of fludarabine levels. This was like a mathematical formula calculating the exposure based on the dose received, the weight of the patient, the creatinine increments, and so on. And we thought that, okay, this works, but maybe what we should do is to measure the fludarabine levels of the patients. And this is exactly what we did. We ran a prospective study. This was financed by the Instituto de Salud Carlos III, but of prospectively collecting samples at these time points that you can see here on day 1, 2, and 3 of lymphodepleting chemotherapy at different time points, a total of 7, and then measuring the fludarabine concentration in each sample and then calculating the AUC. And the first thing we done, and this is work by Mario Sanchez from our group, is that indeed there was a difference between the estimated and calculated levels and the measured. And there was a 20% deviation of the when we did only the mathematical calculations. So the first thing is that we believe that it is important to measure the the actual concentration. And you can see there are some patients, I don't have the pointer, I believe, but who have a great disparity between the measured and estimated, even with 200% deviations. So in those particular patients, it's especially relevant to measure the cells. And now we are expanding this study with pharmacogenetic studies, trying to demonstrate that these patients have particular polymorphisms that make them more sensible to fludarabine. And then, of course, we wanted to see the impact of this exposure on the outcome. And although the numbers are low and this was not statistically significant, you can see that there were some differences both in the multivariable analysis and the survival analysis, showing that patients who had an optimal exposure of fludarabine did better after CAR T cells than those who did not. And finally, and this is work in progress, I cannot show a lot of this, but we are also building a PK model based on CAR T cell patients, because the previous fludarabine PK models were based in the transplant population that was treated 30 or 40 years ago. And this is a completely different population than the CAR T population. And we are building our own PK model that we expect to publish pretty soon, and which is quite different than the transplant model. And with this, we believe that we could use the theoretical models, but a model that is based in the CAR T patients, because measuring fludarabine concentrations in the daily life of patients and hospitals is not that easy. And I'm going through the end of my talk, and I want to talk on the treatments that are given once the patient relapses. And I want to focus here on bispecific antibodies. Bispecific antibodies, you know, are IgG dual antibodies that once they, on one side, they link to the T cells, usually CD3, and on the other side, link to the target cells, in this case, CD20, because most of these aggressive lymphomas express CD20. There are several on the market. They have differences between themselves. I don't want to go into detail. And also just to mention that these agents have similar toxicities, both in terms of CRS and ICANS, and also some similarities in the way they work, because they involve T cells in both cases. So there was the question, or there is, I would say, still the question of whether we can use CAR T cells before bispecific antibodies, or the other way around. We can use bispecific antibodies after CAR T cell. The good thing of these products is that are off the shelf. So we are skipping all the process that I showed you at the beginning, and these are stored in the pharmacy, and these can be delivered to the patients in hours, which makes life, at least our life, a bit easier. This is a summary of the clinical trials of T-cell engagers. All of these are CAR T cells, and recently we have had approvals of epcoritamab and mosunetuzumab and others in lymphoma. So let's go on this first sequence first. So what about patients who fail or have relapsed after CAR T cells, and then they receive bispecific antibodies? We have some data from clinical trials here, and I'm showing here, for instance, the data with epcoritamab, and you can see here the responses of CAR T naive patients, 42% of complete responses compared to 34% to those who were CAR T exposed. This is relatively similar. The numbers are low. However, patients who had been refractory to CAR T cells, these numbers are quite low. So it seems that maybe the issue is not having received prior CAR T cells, but having failed to CAR T cells. So probably there are similar resistant mechanism between the two, and there are interesting studies that I'm sure some of you may be working on, and others that have been published in terms of T-cell fitness and so on. And this is data from glofitamab, again, very low number of patients, showing that the responses were similar in patients who had received or not CAR T-cell therapies. But what about the other way around? So treating with CAR T cells patients that had been previously exposed to bispecific antibodies. And on that, we did a joint study with a French group trying to answer to this question. So we identified 47 patients who had been treated with CAR T-cell therapies and had been exposed to bispecific antibodies. We try to describe the safety and efficacy of CAR T-cells in these patients, and then we compare these with a control cohort of almost 1,000 patients that were registered in the French registry, the CART, that were bispecific naive. So in terms of toxicity, we observed 80% of CRS, 6% of grade 3 or higher CRS, 23% of ICANS. That's that's numbers that are very similar to the bispecific naive population. And then when we compared, you can see a p-value of 1. The outcome, the safety outcomes of these patients were exactly the same, whether they had been exposed or not to prior bispecific antibodies. In terms of response, we observed pretty much the same, 43% of complete remissions, 55% overall survival at 1 year. These are pretty standard numbers. And importantly, the outcome of CAR T-cells was not dependent on the response to bispecifics. So here, apparently, in this small series, but still this was published in Blood and was the first study focusing on this issue, having responded to bispecific antibodies did not seem to impact on the outcome of CAR T-cells. And you can see here the survival plots showing that at least patients who had been exposed to bispecifics did the same, if not better, than patients who had not. If you want to discuss on what this trend towards a better outcome in these patients, I have to say that patients who had been exposed to bispecific antibodies before were patients included in the clinical trials, because bispecific are not approved in the indications before CAR T cells. So probably these were the patients that were more fit. But still, the point here was not to identify whether these patients were better, but still to answer the question of whether we can use CAR T cells in patients who have previously exposed to bispecifics. And with that, I'd like to conclude with a summary of these four studies. I think we have shown that the recent use of bendamustine, let's say 9 months, of course, the risk is continuous, prior to CAR T cell therapies has a deleterious effect on the outcome of these patients when they are treated with CAR T cells. However, when bendamustine is used as bridging therapy, the outcome is pretty much the same, and you can use this agent without any problems. And there have been other publications showing that. Regarding lymphodepleting chemotherapy, the use of fludarabine seemed to matter, and optimal cutoffs are important, and optimal AUCs are important when patients have so on the outcome of CAR T cells in these patients. We still have to determine how should we measure it. I believe that we should measure the fludarabine concentrations at least until we have a PK model, but certainly this has an impact on the outcome of patients. And apparently we can use CAR T cells quite safely in patients who have been exposed to prior bispecifics. And with that, I just want to acknowledge our fundings and collaborators, and a special thanks to my small but very motivated group at VHIO. And thank you very much for your attention and the kind invitation.
Thank you very much, Pere. Before giving the chance to the audience, so we have 3 or 4 questions. Very general, you will see. The age of the donor matters in the efficacy of the CAR? The age of the donor?
Well, these are autologous products, so there's no donor actually.
The auto donor.
The donor is the patient, right? So,
but not that treatment. Is that just the age?
So the age doesn't seem to be important. However, there is a selection bias for sure. So when we have a 30-year-old patient, we basically treat all of them. When we have a 75-year-old patient, we might select this patient. So, but in terms of like T cell function, I'm not aware of studies looking at the functioning of CAR T cells, but of course, T cells in older patients should be worse. So I think this is relevant for the allogenic platform, which I did not discuss, but probably these products will need to be taken from young donors in this case.
So in this regard, I understand also that the pediatric BLL does much better than the adult BLL. No?
Yes, this is the case with all treatments in ALL. I did not cover ALL. The responses are quite similar. There's pretty much like 80–90% of responses, but it's true that pediatrics tend to relapse less. So that would be an indirect explanation for that too.
And the B-cell lymphoma will be at the end of the spectrum. Is the worst of the three, no? Pediatric, adult.
So this is a bit different. So in leukemia, like basically all patients respond, but they continue to relapse from the follow-up. Here in lymphoma, we have like 60% of responses, or 40% are refractory, and we know that at 1 month, but only 20% of these patients will ultimately relapse. So the pattern is quite different. At the end, you end up with long-term survivors of around 40% in both cases, so not that different.
And do you think this relates to the microenvironment in the lymphoma, or not? It relates to the lymphoma itself?
I think microenvironment plays a role, and which is completely different from lymphoma to leukemia, and also the exact constructs that we have. So in leukemia, we know that persistence is more important, and in lymphoma, we know that the hit is more important. So probably I did not mention that, but the CAR T cells that have CD28 as costimulatory domain, which have a higher peak, work better in lymphoma, and the 4-1BB, which is associated with better persistence, work better in leukemia.
Thank you. Questions?
Hi, Pere. Very nice presentation. Thank you. I have a couple of questions. First, regarding the sequencing of treatment. So according to your presentation, so we may think that CAR T cell has definitely won the fight between CAR T cell and bispecific antibodies as second-line treatment, but is there still room to include bispecific antibody as second-line treatment? And the second question is regarding the depletion protocol. Do we know if this different therapy could impact the efficacy of bispecific antibodies?
Of what would impact what, sorry?
Of the bispecific antibodies.
What would impact that?
Lymphodepletion.
Lymphodepletion, okay. At this point, bispecific antibodies are approved in third line, and CAR T cells are approved in second line in most patients. So the current pathway for patients is receiving first CAR T cells and then bispecific antibodies. However, bispecific antibodies have good thing that there are not cellular therapies that can be easily combined with other chemotherapies, and bispecifics are being investigated even in first line in combination with chemotherapy. So my personal opinion is that we will be seeing combinations of bispecific antibodies and chemo in the first line, and probably we will leave CAR T cells in second line. CAR T cells are being investigated in high-risk first line, but the comparator are not bispecific antibodies. So my guess is that we will have probably positive trials in first line saying that CAR T cells are better than chemo, but we will not have a trial comparing CAR T cells and bispecifics in first line. Regarding the second question, bispecifics are given directly and there is no lymphodepletion. So there's no impact there on lymphodepletion. There's no lymphodepletion for bispecifics.
But I mean, for these patients who receive a lymphodepletion protocol before CAR T therapy.
Oh, okay, I see. Yeah, I see where you're going. So you maybe thinking that the lymphodepletion can impact on the how the T cells are, right? I'm not aware of data on that. Usually, like there is at least 2 to 3 months from lymphodepletion to relapse, so you have a room there. But I think something have to be seen from the data we have. They seem to work similarly as I showed, but there is no like translational data looking at that yet.
So you show that bendamustine has a negative impact, but are there any drugs that have a positive impact, like BTK inhibitors in CLL? If there is the same for lymphoma?
Yeah. So yeah, BTK inhibitors are mostly used in CLL and mantle cell lymphoma. And in CLL, there are a few trials showing that maintaining the BTK inhibitor during apheresis and even during CAR T cell therapy, so these combinations seem to improve like the expansion and maybe the clinical outcomes. The problem is that CAR T cell therapies are not used in CLL because in CLL there are so good drugs that probably you don't need CAR T cells, or at least in the vast majority of the patients. In mantle cell, there are some translational studies showing the same of this potential benefit, but this clinical data on that has not been published yet, as far as I know.
And since treatment has a negative impact, it has been considered to cryopreserve T cells from patients?
Yeah, it's a good question as well. Yes, there is some data on that. So there is a study from Israel showing this benefit in terms of T cell functioning, CAR T cell functioning, and apparently also in clinical outcomes. There is an important barrier in terms of logistics and costs, because at the end of the day, it's very difficult to know which patients will be candidates. We do have some risk factors, genetic risk factors, but you should do that at the beginning before chemotherapy, and then you will be collecting a lot of cells that you might never be used for these patients. So I think from a viability perspective, this will be hard to see like wide or to all patients, but maybe in very high risk patients, P53, non-GCB or diseases like that, where you know that these patients apparently will not respond to first line. Maybe this subset of patients would be interesting to collecting cells.
So I was wondering about the mechanism of resistance of these CAR T therapies. Usually, most of the time, they reduce the target, right? So I was wondering if you have this double check to check about the levels of the target before the biospecific treatment.
You mean checking on the antigen after CAR T cells and before bispecifics? To see.
Exactly.
So the bispecifics that are approved right now are directed against CD20. Most of the CARs are directed against CD19. But yeah, it's true. It's something that's been looked at. We have there is data out there showing that around 20% of the, or 25% of the patients that have been exposed to CAR T cells are CD19 negative. This is even more frequent in leukemia than in lymphoma, which is not routinely used, the determination of CD19, at least from now. I'm not aware of a downregulation of CD20 in patients who have been exposed to CD19 CARs, and I don't see why it should be the case. But in all trials with bispecifics, they usually require CD20 determination after every therapy, no matter CAR T cells or another one. Thank you.